senior physician with us who needs no introduction, Dr. Kiran Shah sir, who has vast experience in this medical field and in diabetes also. And he has great experience in using GLP-1 receptor agonist also. So without wasting much time, I asked Dr. Kiran Shah sir to start his presentation. Over to you, sir.
Okay, so good evening, everyone. First of all, I am very much thankful to IMA President Dr. Mitesh Bhai, Dr. Kapadia, and Dr. Niraj Bhai for creating such a wonderful platform and operating such type of wonderful platform for scientific discussions. I am using this platform for the first time. Hope this will be utilized more and more in the future also. So without wasting much time, I am going to start with my talk. Okay, so let me share my talk presentation. Okay, it is visible, everyone? Hello?
Yes, sir, it is visible, sir.
Okay.
Screen is visible.
Okay. So without wasting much time, today I am going to speak on cardioprotection in type 2 diabetes mellitus, specific focus on GLP-1 receptor agonist. So let me tell you that this is the brief outline, that is diabetes and cardiovascular disease epidemiology, the pathways of severe risk in type 2 diabetes mellitus patients, special focus on South Asians, importance of glycemic control for controlling CVD in type 2 diabetes mellitus, cardiovascular risk in type 2 diabetes mellitus patients, cardiovascular outcomes in type 2 diabetes patients, evidences available, recent guidelines, profiles of anti-diabetic medications and selection in clinical practice. And what we should know is that paradigm shift in type 2 diabetes mellitus management in recently. So coming to the first aspect, that is diabetes and cardiovascular disease. We all know that diabetes and cardiovascular disease is a leading cause of death due to non-communicable disease across the world. Annual deaths due to cardiovascular disease across the globe is 17.5 million per year. In India, it amounts to about 2.5 million. Diabetes and CVD adults with diabetes and CVD, adults with diabetes are 2 to 4 times more likely to die from heart disease compared to those without diabetes. This means that 80% of all deaths in diabetes patients is due to cardiovascular disease. So this is very important that adults with diabetes are type 2 diabetes are 2 to 4 more likely to develop cardiovascular disease compared to someone without type 2 diabetes. This is the most important aspect of the cardiovascular disease burden in type 2 diabetes. Let us see the economic burden of diabetes and cardiovascular disease. If someone is having a type 2 diabetes mellitus and cardiovascular disease, the cost per patient is equal to around 3 times more than those who are having a type 2 diabetes only without any CVD. So if a person is having a type 2 diabetes mellitus without CVD, it is 1 rupee, then the type 2 diabetes mellitus with CVD, it amounts to around 3 rupees per cost. Another important thing is that type 2 diabetes mellitus plus cardiovascular disease is equal to 7 times the cost of no one disease, means no diabetes and no cardiovascular disease to manage. So this is a very, very huge burden, economic burden in the society. Another important study published in 2020 diabetic ADA conference, that a capture study, which is a very, very alarming study, and it has provided very alarming signals. We have to roll up our sleeves. What this study says that these studies found that 1/3 of all people with type 2 diabetes have established cardiovascular disease. Remember that 1/3 of all people with type 2 diabetes have established cardiovascular disease. Not only that, implication is that 9 out of 10 people with type 2 diabetes and established cardiovascular disease have atherosclerotic cardiovascular disease. This is another important aspect. And 2 out of 10 people with type 2 diabetes and atherosclerotic cardiovascular disease are getting a glucose lowering treatment with a proven cardiovascular benefit only. So, out of 10, only 2 people are getting an adequate, proper cardiovascular benefit treatment in type 2 diabetes. This is the very, very alarming signals. So we have to roll up our sleeves.
Kiran sir.
Yes.
Sir, sorry to interrupt you. Vijay here. Sir, slides are not moving, sir.
Here it is moving for me.
Sir, in my screen, and I received the call from another doctor. The introductory slide is on screen. It is visible, sir. Slide is not moving, sir.
Okay. So what can I do for that?
Sir, for that, I think you have to reshare the slides, sir.
Reshare. Okay.
હા એટલે સર ફરી શેર કરો એક વખત એને પ્રેઝન્ટેશન ને ઓફ કરીને ફરી કદાચ શેર કરવાથી થઈ શકશે if I'm not wrong. Piyush bhai, can you help for that? Piyush bhai.
Sir, do you need any help with that?
Is it moving now?
I can't see the slides, sir.
No, sir. Slides are not visible. Piyush bhai, if possible, can you help out? Now it is moving, sir.
Okay. Is it
is
moving?
Diabetes and cardiovascular disease. I think it's
Yes.
slide number 2.
Sir, please try going one slide behind or ahead.
Here it is not moving. On my screen, it is not moving.
Okay, please just click on it, sir.
Yes, is it
Yeah.
moving?
Yes, it is moving now.
It is moving, sir. Yeah. It is
Okay,
moving.
yeah. Please, please continue, sir.
Thank you, sir.
So you have seen only the first slide, okay? Okay.
Yes, sir.
So we are going to discuss today regarding this cardiovascular protection in type 2 diabetes mellitus. There is a brief outline. Diabetes and cardiovascular disease, epidemiology, pathways of severe risk in type 2 diabetes mellitus patients, special focus on South Asians, importance of glycemic control for controlling CVD in type 2 diabetes mellitus, cardiovascular risk in type 2 diabetes mellitus patients, cardiovascular outcomes in type 2 diabetes patients, evidences, recent guidelines, profiles of anti-diabetic medications and selection in clinical practice, and paradigm shift in type 2 diabetes mellitus management. Coming to the first part, that is a diabetes and cardiovascular disease. So the diabetes and cardiovascular disease, you must know that it's a leading cause of death due to non-communicable disease across the world. Annual deaths due to cardiovascular disease amounts to 7.5 million across the globe. In India, it amounts to around 2.5 million per year. Diabetes and CVD. Adults with diabetes are 2 to 4 times more likely to die from heart disease compared to those without diabetes. That means 80% of all deaths in diabetes patient is due to cardiovascular disease. So people with type 2 diabetes are 2 to 4 times more likely to develop cardiovascular disease compared to someone without type 2 diabetes. Let us see the economic burden of diabetes and cardiovascular disease. The cost per patient to those who are having the type 2 diabetes and cardiovascular disease is equal to 3 times higher than type 2 diabetes without cardiovascular disease. Another important thing is that type 2 diabetes mellitus plus cardiovascular disease the cost is equal to 7 times more than those who are not having a diabetes or cardiovascular disease. So it amounts to a tremendous economic burden into the society and the nation. One of the most important study, it's an alarming study or signal providing study, which has been published in 2020 ADA conference. So what is this study says? This study found that 1/3 of all people with type 2 diabetes have established cardiovascular disease. And the implication of this is that 9 out of 10 people with type 2 diabetes and established cardiovascular disease have atherosclerotic cardiovascular disease. Another important thing is that 2 out of 10 people with type 2 diabetes and atherosclerotic cardiovascular disease are getting a glucose lowering treatment with a proven cardiovascular benefits. Means ideal optimum management of cardiovascular disease in type 2 diabetes mellitus patients, only 2 out of 10 are getting. So this is a very, very alarming signals. It's time for us to roll up our sleeves. Let us see the pathways of cardiovascular disease risk in patients with type 2 diabetes mellitus. We all know that these social and environmental factors, that is a physical inactivity, poor diet, smoking, and obesity contributes to the development of type 2 diabetes mellitus. So in this social and environmental milieu plus type 2 diabetes along produces the pathophysiological changes, that is a dyslipidemia, hypercoagulation, platelet activation, metabolic dysfunction, environment pollutions. In turn, this will lead to endothelial dysfunction, arterial stiffness, inflammation, and oxidative stress, and this will contribute to the cardiovascular disease. So that is a very notorious milieu of type 2 diabetes mellitus and cardiovascular disease. Let us see the type 2 diabetes mellitus and cardiovascular disease. In South Asians compared to Europeans. Time from diabetes diagnosis until first MACE, that is major adverse cardiovascular event, was found to be significantly shorter in South Asians compared to the Europeans. So this is one of the most important aspects if we compare ourselves with the Western publics. So it is somewhere around 4.5 years earlier we got the diabetes and major cardiovascular events compared to the Western population. Therefore, severe risk management demands an early aggressive approach in South Asian type 2 diabetes mellitus patients. So this is a very, very important aspect if we are managing our diabetic patients. Another important thing, how it is in Indians are more specific in that way. CV complication is of the special interest in Indians, especially people with diabetes who are at higher risk. The relative risk of coronary artery disease associated mortality in Asian Indian is 20 to 50% higher than other population. The prevalence of coronary heart disease in the US is around 8%. The prevalence of coronary artery disease risk in Indians living in India, it's 11% for individuals without diabetes and 21% for people with diabetes. So believe that. Remember that is a very high compared to the Western population. The cardiovascular disease burden in type 2 diabetes mellitus patients is relatively higher in Asian and particularly in Indians. Now let us see the importance of glycemic control for controlling cardiovascular disease in type 2 diabetes mellitus patients. We know that the multifactorial factors in management and choice of therapy in type 2 diabetes. Nowadays, it is not only a one, that is a glucose management is an important aspect in the management of type 2, but there are multifactorial approach in management and choice of therapy in type 2 diabetes mellitus. That contributes, includes current lifestyle, comorbidities associated with it, that is ASCVD, atherosclerotic cardiovascular disease, CKD, heart failure, clinical characteristics, that is age, HbA1c, weight of the patient, individualized HbA1c target, impact on weight and hypoglycemia, side effect profile of medication, and choose regimen to optimize adherence and persistence. So these are the multiple factors we have to consider while management of the type 2 diabetes mellitus patients. And as per the ADA 2022 recommendations, these we have to consider while the selection of the patients and choosing a specific therapy. This is specifically mentioned in 2022 ADA's position statement. We have to set a target HbA1c for patients at high risk for or with established cardiovascular complications. HbA1c target can be less stringent. You can see specifically you can see here that established cardiovascular complications, we can have a lower lower or stringent HbA1c target if someone is having a high risk for cardiovascular complications. And we have to consider all these factors, that is a risk potentially associated with hypoglycemia and other adverse effects, disease duration, life expectancy, important comorbidities, vascular complications, patient preference, and resources and support. And so it's an individualization basically. More stringent action, if it is HbA1c is less than 7, or more stringent action is required, or less stringent is required, we have to consider or we have to select according to the individual patient's need, looking at all other parameters. What are the advantages of lowering HbA1c? We must know that the reduce in HbA1c is associated with a reduced risk of complication. That is already been established fact. It reduces myocardial infarction by 14%, all-cause mortality by 14%, death related to diabetes by 21%, any endpoint related to diabetes by 21%. So lowering HbA1c is associated with the reduced complications of diabetes mellitus and cardiovascular complication as well. This is the most important advantages of lowering HbA1c or having a good glycemic control. Thus, it is evident that from all these pathological pathways and these benefits of lowering HbA1c, diabetes itself is a risk factor cardiovascular event. Comorbidity associated with diabetes further increases the risk of cardiovascular event, and therefore it is necessary to have a good glycemic control and protect the heart. Now coming to the cardiovascular risk in type 2 diabetes mellitus patients. We must know that there are 3 categories as per the cardiovascular risk categories in patients with type 2 diabetes mellitus. That is moderate risk, high risk, and very high risk. Although there is no risk is mentioned, because diabetes, whenever there is a patient, it itself contribute to the risk for the development of type 2 cardiovascular complication. Moderate risk category means those patients who are having a young patient, that is type 2 diabetes mellitus, aged less than 50 years, with diabetes mellitus duration less than 10 years. Means those who are having a diabetes of less than 10 years duration and their age is less than 50 years without any other risk factors, they are having a moderate risk. High risk means those patients who are having a diabetes mellitus duration of more than 10 years without target organ damage, but there is any other additional risk factor. So this contributes to high risk. If the diabetic duration is less than 10 years, means it is the more than 10 years, means it is a high risk, even if there is no target organ damage. Now, the very high risk group comprises patients with diabetes and established cardiovascular disease or other target organ damage of 3 or more major risk factors, or early onset type 1 diabetes mellitus of long duration of more than 20 years. These all patients mean whenever there is established CVD and diabetes or other target organ damage, that is nephropathy, retinopathy, or left ventricular hypertrophy, like that, then they all contribute to very high risk factors, very high risk patients. And early onset of type 1 diabetes mellitus of long duration, that also contributes important to high risk category. Major risk factors that includes are age, hypertension, dyslipidemia, smoking, and obesity. So anyone, if it is present 3 or more risk factors is present, then also the patient with type 2 diabetes are considered to be a very high risk category patients. We must remember that not all antibiotic drugs are having an equal ability to reduce cardiovascular risk. So there are basically two groups: those who are having a decreased CVD risk and those who do not have effect on cardiovascular disease risk. Among these two important molecules that are previously we had using is pioglitazone and metformin. Associated of why pioglitazone is having a good or decreases CVD risk, because they have definitely a protection onto the myocardium. But one of the most important side effects of this pioglitazone is that it produces water retention and sodium retention, and it has not included in good cardiovascular protection group medicine. So we are having two most important drugs, that is GLP-1 receptor agonist and SGLT2 inhibitors, which are having a definitely proven cardioprotection, and that definitely decreases the cardiovascular disease risk. Whereas all these newer and old, that is DPP-4 inhibitors, sulfonylureas and insulins, are having a no effect on cardiovascular risk, disease risk management. Now coming to the pathophysiology of diabetes mellitus and GLP-1 action. What are these? We must remember that there is a multifactorial pathogenesis of type 2 diabetes mellitus. We must know that hyperglycemia is contributed not only by the decreased insulin secretion, but is also contributed by the increased hepatic glucose production, decreased incretin effect, increased glucose reabsorption, neurotransmitter dysfunction, increased lipolysis, islet alpha cell, increased glucagon secretion, and decrease of glucose uptake. So insulin resistance in the muscle and liver and beta cell failure represent the core pathophysiologic effect in type 2 diabetes but mellitus, but we have to consider all these other factors that contribute to the pathophysiology of type 2 diabetes mellitus. The fat cell, GI tract, alpha cell, kidneys, and brain, and all play a major important roles in the developing glucose intolerance. So this is considered as the octet or octet of the Di-Franco, which has been put forward this theory in 2010 by Di-Franco. So this is the most important in knowing the pathophysiology of type 2 diabetes mellitus. Now, how this GLP-1 receptor agonist help? We must know that whenever we take the food intake, very shortly I will explain this, how GLP-1 receptor helps. Whenever we take the food intake, there is a liberation from the intestine, the GLP-1 peptides. With these active GLP-1 peptides are immediately neutralized by the DPP-4 inhibitors enzymes, then it becomes inactive. So it becomes very important. This we must keep in mind. But if there is active GLP in the intestine, what are the actions? It has actions on the pancreas. It has actions on the insulin secretion beta cells. So it increases the insulin secretion. At the same time, there is a glucagon suppression from the alpha cells. It has also, this active GLP-1 has also direct effect on this intestine at the stomach level, and it increases the or decreases the gastric emptying. So the food retains inside, and with that, there is a satiety of these patients decreases. So slowing the gastric emptying helps in decreasing the satiety of the patient. So this is basically the GLP-1 receptor agonist actions. So GLP-1 receptor agonist is resistant to DPP-4 inhibitor. If we give GLP-1 receptor agonist from outside, it is not being degraded by the enzyme which is present in the intestine, that is DPP-4. So this is the most important aspect we must keep in mind. Now, how this GLP-1 receptor agonist targets multiple pathophysiology effect of type 2 diabetes mellitus. We all know that impaired insulin secretion, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake, increased glucagon secretion, decreased incretin effects are the main pathophysiologic effect in the type 2 diabetes mellitus. And these GLP-1 receptor agonists are having actions on this particular pathophysiologic effect that is present in the type 2 diabetes mellitus. It has no effect in the increased lipolysis or increased glucose reabsorption. So out of all these 8 pathophysiologic defects, these GLP-1 receptor having the effect on this particular 6 pathophysiological upset, pathophysiological defect in type 2 diabetes mellitus. So it's an ideal option for the vasculo-glucocentric approach when we are managing the type 2 diabetes mellitus patient. Now coming to the cardiovascular outcomes in type 2 diabetes mellitus patients. What are the evidences in type 2 diabetes mellitus for the protection of the cardiovascular outcomes with the GLP-1 receptor agonist? Let us see for that. And GLP-1 receptor agonist potential benefits, glycemic control and anti-atherosclerotic benefits. We must remember that in a very briefly, I will tell you that this GLP-1 receptor targets multiple organs to improve glucose control in type 2 diabetes mellitus. This GLP-1 receptor acts directly and indirectly on several peripheral tissues that contribute to lowering of blood glucose levels. These include potent effect on the pancreatic beta cells to stimulate insulin secretion, inhibitions of alpha cells for the regulations of the glucagon that reduces the hepatic glucose production, a decrease in the gastric motility, and a reduction in the appetite that contributes to weight loss, reduced levels of adipocytokines, and decrease inflammation. So this is the most important physiological effect of this GLP-1 receptor. And we must know that atherosclerotic potential of GLP-1 receptor action. So it is the direct action of GLP-1 receptor action on blood vessels and macrophages and on the regulations of plasma lipid profiles, which may impact the development of and progression of the atherosclerotic plaques. So this is the important aspect while managing the cardiovascular benefits of this GLP-1 receptor agonist. The inflammation plays a very important role in the development of atherosclerosis, that we already know how this inflammation plays an important role in the development of the atherosclerosis, oxidative stress and other things. So accelerated development of atherosclerosis takes place in the diabetes mellitus. Not going into the much detail. There is a potential mode of action on GLP for the GLP-1 receptor agonist to impact the CVD. Not going on to all this because it decreases inflammation, increases glucose, decreases ischemic injury, increase LV function, increase heart rate, decrease inflammation, increase endothelial dysfunction. All this is a very important, and these GLP-1 receptor have a definitely negative impact in that, on this all the pathophysiological factors, which plays an important role in the development of cardiovascular disease. It reduces inflammation, increases plaque stability, and prevention of progression of atherosclerotic plaque. So this is the most important, and we can say this is the only or most important factor which helps in having the benefit of this GLP-1 receptor, particularly in the cardiovascular protection. Now, what are the cardiovascular outcome trials? Comparison of cardiovascular outcome trials, particularly that for the GLP-1 receptor agonist. Out of this, there are trials which has been published in relation with the GLP-1 receptor agonist. CVOTs are Leader, Sustain 6, Elixa, Excel, Rewind, Harmonium, Pioneer, and others. We can say from this that out of all this, the Rewind is the most important study which has provided the effects of dulaglutide, in which the Rewind study, the dulaglutide was used, and we can say that it is the longest in terms of study, that is 5.4 years follow-up. It is the highest number of the patients, that is 9,901. Not only that, there are variety of patients, that is a secondary prevention or those who are already established CVD, and also primary prevention with risk factors of cardiovascular disease. Whereas in all other, you can see that in majority of the CVOTs, they have included only those patients who are having established cardiovascular disease. Whereas in Rewind study, they have included 69% of those patients who are having a not established CVD, but only those who are having a high risk for development of cardiovascular disease. So this is the most important aspect of this REWIND study. This leader sustained 6 ELIXA and have used the different these GLP-1 receptor agonist molecules. Now the comparison of CVOTs. Another important thing, or what is the result of this cardiovascular outcome trials? We can say that in REWIND trials, when we have used the dulaglutide, it reduces the primary composite endpoint, that is 3P MACE, that is composite of cardiovascular death, non-fatal MI, non-fatal stroke, by 12%. So this is the most important aspect of the REWIND study. All this study, that is leader, sustain, REWIND, harmony, and amplitude study, have definitely shows a clinical significance, that is a primary composite endpoint reduction when there is a secondary prevention or established CVD. So this ELIXA and EXCEL and this pioneer study does not provide any significant improvement in cardiovascular. So these are considered as the positive cardiovascular outcome study, that is leader, sustain 6, REWIND, harmony, and amplitude. So among the GLP-1 receptor agonists, liraglutide, semaglutide, that is injectable, and now oral semaglutide, dulaglutide, albiglutide, and epiglanetide have demonstrated protection against major adverse cardiovascular events, whereas others have failed to demonstrate the cardiovascular protection. So all these anti-diabetic drugs are not equal even in a single group. That also we should keep in mind. Among the positive cardiovascular outcome, majority show cardiovascular prevention only in patients with established cardiovascular disease, that we had already seen in this leader trial or sustain trial. Those who are having established cardiovascular disease, then only they are showing some benefits, whereas those who are having no clinical benefit has been reported in those as a primary prevention. So whereas in REWIND trial that has used those patients who are having a primary as well as established secondary cardiovascular disease, it shows that there is a definite 3P MACE reduction, that is by 12%, despite majority of the patients not having established CVD. So it's a very important that even up to the follow-up of 5.64 years, at the Kaplan-Meier curve sustained to diverge within the first year. So it shows that the cardiovascular protection is definitely there with the primary prevention as a primary prevention or as a secondary prevention. Means though it is also helpful in those who are having already established cardiovascular disease or those who are having a high risk. So this particular molecule is very definitely helpful in using it as a primary prevention as well as secondary prevention of cardiovascular disease in type 2 diabetes mellitus patient. So this is the same thing what I had told, that dulaglutide reduces the risk of major cardiovascular events such as non-fatal MI, non-fatal stroke, cardiovascular death in adults with type 2 diabetes mellitus with or without non-CV disease. Now let us see the guidelines, what this recent guideline says. ADA 2022 recommendations. Clearly, it has a important advancement in that pharmacology treatment of hypoglycemia in adults with type 2 diabetes mellitus. The first line therapy depends on comorbidities, patients' center treatment factors, including cost and access consideration, and management needs, and generally includes metformin and comprehensive lifestyle modifications that we already know since long. Now, whenever there is a presence of these patient-centered treatment factor, particularly the management needs and comorbidities are patients, we have to consider other things also. That is ASCVD, indicators of high risk, heart failure, and CKD. Whenever these patients things presents, we have to consider the first line therapy choice, not others than this particular thing, and recommends independently of baseline HbA1c. Even choosing this, they recommend that we can choose such type of molecule irrespective of the baseline A1C, individualized A1C target or metformin use. So whether we have used metformin or not, whether the A1C is lower or not, or whether we have able to reach A1C target or not. But if ASCVD, indicators of high risk, heart failure and CKD are present, then we can use newer molecules, that is particularly SGLT2 inhibitors and GLP-1 receptor agonists. So this is the very, very important new development in the recent guidelines. So here this particularly highlighted this, the same thing what I had told, that among patients with type 2 diabetes who have established ASCVD or indicators of high risk, established kidney disease or heart failure on SGLT2 inhibitors or GLP-1 receptor agonists with demonstrated cardiovascular events are recommended. So this is the most important recommendation as far as selection of the first line therapy whenever there is a presence of these risk factors or comorbidities. Now coming to the profiles of anti-hyperglycemic medications. These in general, the profiles of all available anti-hyperglycemic medication, that is metformin, DPP-4 inhibitors, GLP-1 receptor agonist, type thiazolidines, sulfonylureas plus glinides, insulin, and so SGLT2 inhibitors. We can see this all particularly, and we all know this. This is a very important aspect. As far as the GLP-1 receptor agonist is concerned, it is providing hypoglycemia is very, very less, or HbA1c efficacy is very good, weight loss is significant. Rutilant, and as far as the genitourinary and renal aspect is only exenatide is not indicated when there is a creatinine clearance is less than 30, whereas other all molecules of GLP-1 receptors are very well can be used in renal also, renal impaired also. Even the gastrointestinal symptoms are almost same as that of metformin. So we can say that it is a good, it has definitely a good effect on congestive heart failure, cardiovascular disease, one. So it is a neutral. Now the drug specific and patient factors to consider when selecting anti-hyperglycemic treatment. So these also, we all know that there are multiple factors present in a particular patient. So we have to consider all these factors when selecting the anti-hyperglycemic treatment, and particularly the CV effect that is a present, that is a cardiovascular disease present, that is ASCVD or congestive heart failure. Whenever there is a presence, this contributes an important factors in selecting the molecule for the type 2 diabetes mellitus management. We should not only think about the efficacy, hypoglycemia and weight change, but we also have to keep in mind the ASCVD and heart failure patients. We must know that metformin, SGLT2 inhibitors, DPP-4 inhibitors, thiazolidines, sulfonylureas, insulin, and GLP-1 receptors, we can say that they are having a high GLP-1 receptor agonist having a very high efficacy. It has no or very least effect on the hypoglycemia manifestation. It increases the weight loss, and there is a definitely a CV beneficial effect when we are using this GLP-1 receptor agonist, except lixisenatide, which has not proven beneficial. This liraglutide, dulaglutide, and semaglutide has definitely a proven beneficial effects in ASCVD protection. So there is a paradigm shift over a period of years. Now we can say that in second decade of this 2020, we can say that there is a paradigm shift in type 2 diabetes mellitus management. Initially, we were thinking that the diabetes mellitus management means simply a glucose-centric approach, but it is not so. It is nowadays considered as the vasculo-glucocentric approach rather than only glucocentric approach. Means instead of only managing the glucose, we have to manage complete cardiometabolic centric approach is to be considered. And we, as a physician, there is important to choose a therapy with vasculoglucocentric benefits. So clinician must balance potential side effects with glycemic benefits. So while selecting the CV risk reduction in type 2 diabetes mellitus, we have to see the glycemic control side effects which are least associated, and there is a benefit with the CV risk reduction. So these are repeating the same slide. Not all antidiabetics are having the ability to reduce cardiovascular effects. These are the two newer molecules, GLP-1 receptor, SGLT2 inhibitor. But when to use which particular molecules, that is also an important aspect. So whether we have seen that GLP-1 receptor agonist and SGLT2 inhibitors are the two newer molecules which have shown the cardiovascular benefits. But when to use which? So as per my knowledge and recently, whenever there is a cardiorenal or CKD or heart failure, we have to consider using the SGLT2 inhibitors. But whenever there is atherosclerotic disease or stroke, we have to use the GLP-1 receptor agonist. So particularly in ASCVD associated or cardiovascular protection, we have to keep in mind that whenever there is a cardiorenal, CKD or heart failure, we have to use this as SGLT2 inhibitors, and whenever there is atherosclerotic disease and stroke, we have to consider the GLP-1 receptor agonist. So this is the most important aspect as a physician and clinician we have to keep in mind. Now, what are the recommendations? Based on all these particular available evidences and pathophysiological aspect that we had seen, this recommendations are: bring GLP-1 receptor agonist early in the cardiovascular conversation with patients. So people with high CV risk or clinical ASCVD, CKD or heart failure, when to initiate GLP-1 receptor agonist with proven CVD benefit. Independently of HbA1c, you can use these newer molecules, that is a GLP-1 receptor agonist, that in patients with type 2 diabetes mellitus and indicators of high CV risk or established ASCVD, particularly if ASCVD is predominant, we can use at the time of diagnosis of clinical ASCVD in a patients with type 2 diabetes mellitus. At the time of diagnosis of type 2 diabetes mellitus in patients with high CV risk or clinical ASCVD, we can use this as a first-line therapy. At the hospital discharge also, after admission for an ASCVD or diabetic-related clinical event, we can use these newer molecules as a first-line. Another important advantage of this: bring GLP-1 receptor agonist early in cardio conversation with patients. Traditionally, over a period of 20 years following publications of UKPDS, the management of type 2 diabetes has been predominantly glucocentric, but nowadays it is not so. Recent recommendations have moved towards a more personalized and CV risk focused approach. So it's a cardiometabolic focus, individualized focus and approach. ADA, ESA, ESD, ACC, AHA, ESC recommends GLP-1 receptor agonist or SGLT2 inhibitors in indicators of high risk or established ASCVD, CKD or heart failure, independent of baseline HbA1c. Guidelines recommend GLP-1 receptor agonist with proven CV benefits if ASCVD predominates, and ESC recommends GLP-1 receptor agonist as first-line therapy in drug-naive patient also. Another important: GLP-1 receptor agonist should be brought in conversation with patient when there is a type 2 diabetes mellitus, highly demanding chronic disease. GLP-1 receptor agonists are the ideal cardiometabolic drugs when we need to achieve glycemic targets, to minimize hypoglycemia, to minimize weight gain and promote weight loss, to reduce major adverse cardiovascular events, while intensifying to injectable therapies, and for patients where cost is not a major factor, because ultimately it's a very high glycemic efficacy. It helps in weight reductions, low risk for hypoglycemia, and over and above, it provides a very good CV benefits for cardioprotection. So this is what all I want to tell you. Concluding my talk, burden of diabetes and cardiovascular disease is high across the globe and as well as in India. South Asian type 2 diabetes mellitus patients have a higher risk of developing cardiovascular disease earlier versus Europeans. Thus, management needs to early and aggressive in Indian settings. Recent guidelines support use of cardioprotective anti-hyperglycemic agents were visually, that is SGLT2 inhibitors and GLP-1 receptor agonists in those who are younger type 2 diabetes mellitus patients who are high risk for cardiovascular disease. Several GLP-1 receptors agonists have demonstrated cardioprotection in type 2 diabetes patients with established CVD. And particularly dulaglutide is the only GLP-1 receptor agonist to demonstrate cardioprotection in type 2 diabetes mellitus patients with or without established CVD. One of the most drawback of this till date that it is available as injectable only, but nowadays you all available that since January the oral peptides, that is this GLP-1 receptor agonist is also available, and that is a semaglutide only available in the Indian market also, and probably that will also change the game in the, or it will prove to be a game changer in the diabetes mellitus management. But in Indian setting, the cost is a major factor. Once the cost will be reduced, yes, it will be definitely a game changer in Indian settings. So that is all, and thank you for your patience here.
Thank you very much, sir, for this great talk. I think you have covered almost everything. But there are a few questions. I mean, I am getting one question. Any other questions are also welcome.
Okay.
One of the question is regarding the dose of semaglutide, sir. Dr. Mahima has asked about the semaglutide in cardiovascular patients dose.
Particularly the semaglutide trials are say that it is 7 and 14 milligrams are the available semaglutide dose. That is 7 milligram and 40 milligram tablets are available. But the thing is that it is associated with the GI side effects. And in Indian settings, we can use the 7 milligram is an ideal dose to start with. And if there is no side effects or GI side effects, we can escalate it up to the 14 milligram. That is or when there is demands for more and more glycemic control or more CVD benefits, then we can use or escalate this particular up to the 14 milligram. So to my mind, 7 milligram is an ideal dose of this semaglutide in Indian settings as oral patients.
So Dr. Pranay Waghela wants to know any major side effects or contraindication for the use of GLP-1 receptor agonist.
As we already know that the most important side effect of this GLP-1 receptor agonists are GI side effect, that is nausea, vomiting, abdominal discomfort, abdominal pain, and diarrhea. These are the only 3 or 4 or GI discomfort side effects are present. It has been said that it produces some sort of pancreatic problems, but over a period of time, it has already been found that there is no added malignancy risk compared to the other molecules. So we can use these particular molecules very safely. But yes, whenever there is a presence of certain things like pancreatic malignancies, we should be very cautious, or rather we should avoid this particular molecule.
So how do you handle the cost barrier?
Yes, that is the most important thing. That is what I had also told in Indian settings. Unless there is a cost cut down is there, it's very difficult to increase the use of this particular molecule. But yes, if there is a presence of ASCVD or cardiovascular impairment or cardiovascular disease, we can tell and explain to the patient that over a long period of time, it will be a beneficial, though its initial cost is more. Paying a penny at this junction will be much helpful rather than paying a pound in the future.
Excellent.
Yes.
Excellent. And some patients, when we start specifically convincing them regarding the weight loss, and what if they don't see the weight loss? How long should we wait, and how much weight loss should we expect?
Particularly at present, I I think no one has promoted this except one company that is showing that it GLP-1 receptor should be promoted as a weight loss only. So rather, we can wait up to the 6 months only for having a maximum weight loss. That is what they are recommending, that it produces up to the 3.8 to 5 kg, 5.4 kg weight loss at the end of 6 months. So you can wait up to the 6 months only for weight reduction, if at all you are using it only for the weight reduction purpose.
Sir, is it advisable to use sulfonylureas along with GLP-1 receptor agonist?
I think it increases chances of hypoglycemia, but it is not a specific contraindication. That is what so far I know.
Right, sir. So I think there are no more questions. So it was a wonderful talk, sir. And with this busy IPL schedule, still we had a good number of participation for this talk. Again, I would like to thank you, sir, for this great talk and sparing time for us. Thank you, Sipla. And on behalf of IMA, I thank all the participants for this session. Thank you, sir.
So I am very much thankful to particularly the Niraj Bhai, team, Sipla, and all listeners who has specifically paid attention to this particular talk. And hope such type of talk will go on and on in this particular platform. So.
Right. So with this, we conclude
Yes.
today's session, sir.
Yes, sir. Thank you.
Thank you very much. Thank you all.
Thank you
Have
all.
a good night, sir.
Good night.
Thank you, sir. Thank you, Neeraj sir. Thank you, Kiran sir.
Thank you.